All right, good morning, everyone, and welcome to the CXO Insight session. I'm Lisa Kaplan, Chief Information Officer for HIMSS, and I'll be kicking off the session as well as closing it in a little bit. Health equity is a key focus within our ecosystem, and today we're going to talk about how a broad-based coalition that has been catalyzed by state funding combined innovative care models with digital overlays to create change within a community that drove improved care outcomes as well as more equitable access to care. Today, we have a great group of executive leaders here to talk about their lessons learned and the potential to mirror success in other communities.
2x6s?
Are you going to share?
We have oops. Yeah, mute. Yeah, there you go. We have Nathan Hall from the Chartist Group who will be acting as the moderator today. We have Brenda Battle from University of Chicago Medicine. We have Dr. Barrett Hatches from Chicago Family Health Center. We have Russ Himes from Advocate Aurora Health and Dr. Erica Steed from Sinai Chicago. We, as we kind of go through the agenda today, we'll take you out a little roadmap here. As you can see, we're starting out doing the welcome in the background. Following the presentation of the topic, which will be a Southside case study, we'll then open it up. We'll have a panel discussion where you'll have an opportunity to ask questions. You can put them in the chat. You can raise your hand, whatever works best for you, and then we'll wrap it up. For those of you who are new to the CXO Insight series, those of you who have been here before know the drill, but for those of you who are new, the CXO Insight series was really designed as a community to help navigate digital transformation and really provide a platform for folks to learn, to share ideas, to share their successes, to share obstacles. Really, this work is very, very difficult, as we all know, and it's really great to have a community where we can come together and talk candidly and compare notes around different topics. So we do this virtually like we're doing today, but then we also do it in person at the HIMSS Global Conference. The next global conference will be in Chicago next year. As in past sessions, we will be publishing a paper, sort of gleaning some insights from today's dialogue. So enjoy the session, and at this point, I will turn on over to Nathan.
Great, thank you, Lisa, for the warm welcome. And it's a real privilege to be here this morning with our panelists and with all of you on the line. And our panelists have a great story to tell today about an unprecedented collaboration on the Chicago's South Side to help transform healthcare and address health inequity. The events of the last few years have really brought into sharp focus the need to address health equity. Many of the underlying issues, including structural racism and underinvestment in health infrastructure, just to name a few, these issues are not new. But in some ways, our collective awareness of those issues has increased. And this has led to a critical opportunity to redefine health and well-being for all of our communities, not just those who are marginalized. And as we'll hear from our panelists today, responding to this opportunity requires new models to proliferate locally, regionally, and nationally, which are supported by new funding sources, both public and private, and above all, a real commitment to collective action. Next page, please. Health equity, as Lisa mentioned, and I hope as folks appreciate, is a national crisis for us all. There are massive disparities in access and social determinants of health that have led to terribly inequitable outcomes, as we see on the right-hand side. I think folks are aware of many of the drivers that we have listed here. It's a familiar set of challenges. We see underinvestment in underserved communities, leading to deserts of primary care and a critical access to specialists. We see the regular closure of community-based inpatient care units, creating access challenges in communities across the country. This, combined with unmet social needs, things like underemployment, unemployment, food insecurity, housing insecurity, barriers to transportation, these all mix together for a really sort of toxic mix of inequitable outcomes. And the ones we show on the right here are really just a representation of a broad-based set, but they're very stark. We see 3 times as many Black Americans die in childbirth compared to white Americans, life expectancy gap of 4 years. And just over the last couple of years during the pandemic, Black Americans are twice as likely to be hospitalized and almost twice as many COVID-related deaths as compared to white Americans. Again, this paints a pretty daunting picture and really calls all of us as healthcare leaders to question, what can we do about it? And if we go to the next page, I think what we're starting to see is hope. And hope in the form of local solutions to this national crisis and set of problems. I think, as we all know, healthcare, often like politics, is local. And crafting a response to your own individual communities requires an understanding of the local planning environment, which is different. And I know we've got folks on the line from across the country. And I think you'll appreciate, of course, that the sources of public and private financing that are available, those are going to be different in Charlotte than they are in Chicago. The political environment in Detroit is different than it is in Dallas. The community stakeholders that need to be engaged and activated are a lot different in the Bronx than they are in the Bay Area. But what this means is it calls for customized local solutions. And on the next page, I think it's important, though, not to confuse local solutions with easy solutions. The local solution really does have to solve multiple challenges all at the same time. And we'll have our panel dig in a little bit more here. But question number 1 here is, what's the programmatic model that can address the unique needs of the community? And how is that going to overlap with a sustainable operating model and funding sources over the long term? And finally, what's the community coalition that needs to be recruited and activated to bring this solution to light, to be successful, to be sustainable? And quite frankly, this yellow overlap in the middle, this is the challenge, right? So how do you find a solution that meets all 3 of those other needs while also reflecting the unique history and experience of the coalition? And again, we'll hear a lot from our panelists on that topic as well. And the last thing I'll say before handing over to Brenda, again, I just want to reinforce what our panelists and their colleagues have achieved to date is impressive. It is an incredible story to witness, to see ongoing. We're going to hear about their experience building the coalition. We're going to hear about how they centered the voice of the community in the design and in the implementation of this model. We'll hear about some of the initial workflows and pilots that are being deployed, as well as sort of the work ahead to demonstrate results and ensure a sustainable model. So I'm going to hand off to Brenda Battle, again from University of Chicago and board member of the Southside Healthy Community Organization, to take us through their path to launching the model on the South Side. Brenda.
Awesome. Thank you, Nathan. And thank you to HIMSS for inviting us to talk about our model. We're really excited to do it and excited for the work that we've done over the last almost 2 years, really, since we've been developing the model and actually since early January, executing on it. So if we can go to the next slide, please. So I'm going to give you an overview of the South Side and why transformation is necessary for the South Side. A lot of the things that Nathan just pointed about the national issues related to inequities and health disparities are pervasive on the South Side of Chicago, and in many cases worse in our community than across Chicago, across Illinois, and across the nation. We see some of the worst health outcomes in our community than we see in many places across the nation. And I do want to point out that the South Side was once a very vibrant area with businesses and community and entertainment and a lot of engaged community members that were very involved in the South Side. It was always largely African-American. Now it's largely 74% African-American, 14% Hispanic, and all other else. But now what we see on the South Side, we have one of the worst life expectancy gaps in the South Side than the rest of the country. We have the neighborhood on the South Side compared to the North Side of Chicago with a 30-year life expectancy gap. Nathan talked about this a little bit, but we see 10 times more infant deaths per 1,000 births on the South Side and 4 times the rate of diabetes. And these are just some of the outcomes that we see. Next slide. And to Nathan's earlier point, it's a desert for a number of things. It's a healthcare access desert. It's a food desert. It is an environmental desert, name it, and we've got that on the South Side. After years of disenfranchisement and years of marginalization in this community, these are unfortunately the results of what we see happening for the lives of the persons on the South Side. So we have nearly a shortage of 100 primary care providers. We have I think a large and a high quality, successful group of community health centers, federally qualified health centers. We have fewer safety net hospitals and 1 academic medical center and a community hospital, but we still don't have the coverage and access to primary care. And the result is we see 60% of folks using the ED as their primary care home. We also see higher rates of ED visits for mental health services, and we see a huge amount of out-migration because of access, because of the time that it takes to get an appointment on the South Side. Then 60% of the community actually have to leave the community to get care. And what happens when people have to leave the community to get care? They forego it, they delay it, and then they end up sicker as a result of it. And lastly, we see that 30% of the residents on the South Side live below the federal poverty level. So next slide. So we were fortunate in the state of Illinois that the legislature allocated funding to support communities that had these high rates of disparities to form a collaborative effort, response to these issues, to transform, to fundamentally, not just transform, but to fundamentally transform healthcare within our communities. And so we were fortunate to submit a proposal to the Department of Health and Family Services, asking for $30 million over a 5-year period of time to transform our community. We were blessed to receive $146 million over 5 years for these fundings. But the requirement was that you really had to create a collaborative, coalition-driven solution, that your solution had to address the health disparities that we named and others in our community, and that it had to be input. You had to get input from the community. You had to engage the community around these issues, and the solution had to be driven by that community input as well. And so the result is we formed this coalition of all of the providers on the South Side of Chicago, or the majority of them, 13 of us, 5 safety net hospitals, 6 federally qualified health centers, University of Chicago, and Advocate Aurora, Trinity Hospital, to work together collectively around how we actually address and solve for these issues that we have in our community. We created a governance model that placed each of our institutions with a member as a member of the board. We also have recently hired our CEO. We stood up a not-for-profit organization, the Southside Healthy Communities Organization, recently hired our CEO. That CEO is a board member, and selected 3 community members to also be on the board. And we did a lot of engaged a lot of people over time, and we're continuing to engage in community over this effort to get input and also to inform them of what we're doing. Next slide. think this is my last slide, and this is the solution. We talked about the problem, and so what are we going to do to solve it? We know we have to address the issue of access on the South Side. So we have to increase the number of primary care providers and OB providers in our community, and we have to place them in the community at the federally qualified health centers and at the safety net hospitals. We also know we have to address the unmet chronic diseases, and we have to do it in a collective way. We know we have to work collectively around how do we develop chronic disease management programs, leveraging the community-based organizations in our area to address these issues. We also have a gap in specialty care. So we have to put specialty care at the safety net hospitals where individuals in the community can access them. We also know that our solution involves addressing the care coordination needs and the social-determinant health needs by hiring a team of community health workers and care coordinators and planning them in the emergency rooms at the federally qualified health centers and at community-based organizations to help patients to navigate care, access information, and also get access to the resources of the social determinants of health. And lastly, we are in the process of building a seamless transitions of care system, a technology system that links our care together and enables us to better coordinate care. And you can see at the bottom, I'm not going to go through all of these, but our goal is to reverse the longstanding health disparities. And you can see some of the outcomes that we're intending to achieve there, and reduce the overall cost of care as a result of this connected and collaborative system, and improve the economic sustainability of our community by bringing jobs and access to our community. I think that's my last slide. Yes.
Thank you, Brenda. We're now going to move into the panel discussion. We've got plenty of time for this, folks. I'll start us off with a couple questions, but if people on the line have questions for our panelists, it'll be easier if you put them into the chat. If you also want to try and raise your hand, we'll keep an eye out on the screen, but we'll get to them a little faster if you put them in the Zoom chat. So why don't we start with a question for Barrett. Barrett, how did this coalition come together? This is kind of an amazing group to get together. How did it happen, and what barriers did you face trying to get this group together?
Thanks, Nate. Well, I would say first that, when the questions is asked, what's transformation about this model, I would just simply point to the group of collaborators. The fact that, as Brenda outlined earlier, that we have hospitals, we have systems, we have federally qualified health centers, all working together on the South Side of Chicago is transformational by itself. And so you can understand the challenges of all of us being individual systems inside of this South Side of Chicago, operating independently to come together and work together on a issue as important as and broad as this issue of health equity is absolutely amazing. So it came with its natural challenges. First to roll this out to the community, to ask for their input, not just their input, quite honestly, their guidance on what it is they wanted to see from their perspective, not the healthcare leadership deciding what to take to the community. Oftentimes that's a mistake that we make. We try to give people what we think they want instead of asking them and allowing their input. And so they've not just given input, they've guided the process. They've helped develop this model. They are a part of this model. So that comes with all of its natural challenges, geographic challenges. And in Chicago, geography is important. Communities are important. So every block club, every community has a voice. And we build this model around listening to everybody in this community. The other challenge here is if you open up a model, open up a model like this, where you seek the input from the community, you better be willing to listen. And you better be willing to not just listen, but to implement what they're saying. And so this model was built from the beginning with open access for everybody. So in many cases, we hope that this model becomes something nationally recognized, and we'll be able to point back and say the people in this community, even the people who are accessing the health system, will benefit from this, and they can take ownership in what we're doing. So it was met with all the challenges. But again, I go back and say, because we have these 13 entities plus the community involved in the grassroots, the foundational components of this model, it has a much better chance of being successful.
Thank you, Barrett. Erica, if it's okay, I may ask you a follow-up from what Barrett was discussing around, Barrett, you said if you ask people, you better be ready to implement it. I think that speaks to trust and perhaps a trust deficit that could be present. And Erica, I wondered if you could tell a little bit about how your organization and how your experience over the last 12 to 18 months has helped address or overcome some of those trust barriers kind of within the coalition and between the coalition and the community.
Sure. Thank you so much. And I'm very humbled and honored to be a part of this panel with my colleagues. First, I just wanted to give a brief introduction to myself. I serve as the System Chief Operating Officer and President of Sinai Chicago. So we're a small but mighty force in the Chicagoland area. So we're the largest private safety net a coalition of hospitals in the state of Illinois as well as in the Chicagoland area. We've been around for a greater than 100 years, and our undivided focus has always been to serving the greater good of the community, really driving the eradication of healthcare disparities, really having a unique focus on driving health equity at its best and all things possible, and truly serving as a role model for diversity and inclusion. So we've obviously assimilated over the years in having that particular focus. But one key aspect of the service offerings that Sinai Chicago has to contribute to the table on the Southside Healthy Community Organization has been our community worker program, and essentially serving as that convening body, if you will, to really connect the dots and really be a part of the community, being that central voice and really identifying those gaps and core challenges and driving it home to execution. And I think that one of the beauties of it is our community health workers are typically pillars and staples of the community themselves. So we actually recruit directly from the community. They certainly are fluent with the needs of the community at large and can really hear and heed those various messages. And I think that having that credibility, having that true understanding of those needs, and really driving it home to execution to say, let's put action where the words are. I think that's a critical aspect of really building up and forging that trust. But I can really echo what Barrett just mentioned in terms of the unique aspect of this particular model is many of us have been heavily focused on this individually for many years. But the beauty of this is the strength in numbers and the synergy that has resulted from each of these strong powerhouse organizations really coming together in partnership with the community at the grassroots level, really driving excellence at its best. So I think that all of those components really come together nicely.
Thank you, Erica. Russ, a question for you. As Erica just described, there's a lot of power in bringing together these individual powerhouses and building the solution. And we heard about the community health workers. Brenda also described sort of the technology solution being critical to really bringing this model together over the long term. What's some advice that you would share with the group in terms of how to think about coalition-based technology design that's different from anything else that you've done kind of on an internal basis?
Thank you for, hi, good afternoon, good morning, everybody. And it truly is an honor to be part of this group and on this panel today. One of the most rewarding things that I do in my day-to-day work is work on this project. It's something that's near and dear to me personally, but also extremely important to Advocate Aurora Health to work with our partners to really change the way we deliver care in this community across 15 zip codes, across 13 organizations with a wide range of technology platforms and capabilities. And I think one of the things that we're challenged with as we work on developing this connected care platform, which when we first looked at it, our first reaction was, wow, that's an audacious goal. How are we going to actually do that? And we've gone through a journey over the last 6 months where we've done a traditional requirements gathering and understand what the workflows are going to be for the various team members that are going to be providing care in the communities and within our organizations. And what I've concluded and what we're trying to do from a technology perspective is we have to think differently about how we use our technology platforms. We have to challenge ourselves across three areas, I think. One is our institutional policies and procedures don't necessarily individually lend itself to sharing data across multiple organizations within the community. While the technology and information sharing is absolutely better than it has been ever, there are still some internal institutional barriers that get in our way sometimes about how we will do this. And so that's one thing. The second thing is, there's a lot of talk about digital inequity at the individual level, lack of connectivity and so forth. But we also have to understand that each of the partner organizations are at a different place in terms of what technology they have today, and what technology we're using today, what we need to do to support the workflows and the care design, the model design that's coming at us with this new important initiative. And so how do we level the capabilities and the platform so that we can truly have a connected care platform, not only that allows the healthcare workers and the community health workers to communicate effectively, but we really need to be able to communicate effectively with our patients and the community members who are going to be hopefully benefiting from the services in this new care model. And then lastly, internally, I think there's also some cultural things that need to be thought through in terms of how do we step back and understand the different needs of the community. How do we connect to those community resources most effectively? And so those are the key challenges that we're facing. Just from a how do we pick this technology perspective, one of the most important, we're not really that worried about the technical stuff. I think we'll get the technical stuff right. It's more of the simplicity of the solution, the mission alignment and the strategic fit across all the entities within the coalition. And then how does that really support our patients and consumers to achieve those objectives and outcomes that Brenda just shared momentarily ago.
Thank you, Russ. Maybe we can go back to Brenda. I see there's a question in the chat asking about KPIs and tracking success and measuring success. You alluded, Brenda, to the state process, and I know that the coalition had to make a number of commitments around measurement. Could you share some of those with the group, please?
Sure. When we initially submitted our proposal, we submitted a number of KPIs or metrics that we wanted to achieve. And of course, because this is connected with the broader Medicaid system for Illinois, there were some specific metrics that they also wanted us to achieve as these transformation models, and that we're not the only transformation model. There were 9 other or 8 other models that were awarded funding for transformation in their respective communities as well. So they wanted us to have some connected or linked metrics that we were achieving. And so they're around what you would expect. They're around healthcare outcomes, particularly focused on chronic disease management. They're around ED utilization and access to care after ED utilization, particularly for behavioral health and substance abuse, access to primary care. This is something that I think that our model is doing, and other models as well, increasing access to primary care. There are around patient experience, creating better patient experiences across the coalition. Our metrics are also around certainly addressing the social determinants of health and closed loop, addressing those social determinants of health. And so they're very broad over the period of time, certainly access to OB services. And I think what we're ultimately trying to achieve is a system of care, a connected delivery system of care that gets individuals access to care at the right time and at the right place. And I'd say that all of our metrics are aligned with that mission, but also they're aligned with controlling, reducing the overall cost of care. Because if we create this system of care, in the long run, we should be able to see that we're actually able to control the overall cost of care as well. And so they're broad and wide. Some are some process metrics that are built into the work that we're doing as well, that involve setting up the system, obviously, that's going to enable us to execute on the model that we have. And so we also have metrics around increasing, obviously, the economic sustainability of our community. Therefore, the workforce is important, but also working with minority and women-owned businesses, leveraging those entities and ensuring that we're able to build economic stability through utilizing these sorts of entities to deliver, execute on our model as well. So there are multiple metrics aligned and KPIs aligned to this work. And we think that this sort of model, this sort of solution is what it takes to achieve those.
Thanks, Brenda. And just a reminder to folks to please feel free to type in your questions into the chat. You can message them to me directly if you want me to ask on your behalf. It is a little tricky to sort of follow all the different squares on the screen, but don't be shy. We've got panelists more than happy to answer anything that comes in. Maybe we can go back to Erica just for a minute. You know, we heard from Brenda and some of these commitments around hiring and jobs. You talked about the community health worker program, and there may be folks that aren't as familiar with what those folks are doing. And so can you share within the healthy community model, what are you asking the community health workers to do? And how are they helping address some of these KPIs that Brenda just walked us through?
Sure. So the community health worker model has been a new evolving model over the past decade, I would say. But one of the beauties of this, as I mentioned, is we're hiring community health workers directly from the community. So they're essentially positioned as ordinary lay people who really are fluent in the voice of the community. They're truly serving in multiple capacities, and we're actually having two distinct roles as part of our healthy community model. One is the community health workers, otherwise known as CHWs. And the other is care coordinators, and care coordinators is a different function, is more nursing or social work specific. But the community health workers specifically are resources that are specially trained to really understand how to navigate through the various chronic conditions, concerns, and social determinants of health that we face on a pervasive basis. So one is they're spread throughout the community to really access the community in different ways, to really identify the gaps that we're ultimately challenged with, and brings a much more powerful voice to those various social determinants of health that we're challenged with, like food and housing insecurity, transportation gaps, and other pervasive challenges that we are really suffering through. And they're the connector to the various community-based organizations. So we can actually tightly connect those various linkages. And as Russ pointed out, we're through our connected technology platform, we actually use that as a means of enabling that communication, enabling the ability for us to really connect the community with the various resources that are out there available much more real time, so we can essentially navigate the community through whatever experiences. Ultimately, a measure of success, and this is what, in part, what Brenda was touching on, is a measure of success is if we can keep our community well and out of the hospitals and out of our emergency departments, because using the emergency department as a means of primary care means that we're not navigating in the direction that we want to navigate. So we want to decrease that overutilization and really spread the love and through our primary care and specialty care providers throughout the community. So I would say that the community health worker is that key convening air traffic controller, if you will, to all of those resources available to really address the social determinants of health in a very innovative type of way.
And Nathan, can I add that Erica mentioned the care coordinators, the nurses and social workers that are also helping with care transition and supporting this broader care coordination work. The community health workers and the care coordinations are aligned together to work on this. The University of Chicago has taken the responsibility on behalf of the SSHCO to hire and train the licensed care coordinators, so nurses and social workers, just as Sinai has accepted the role to leverage their long-standing expertise with community health workers to train the community health workers. But these teams of care coordinators, community health workers, and care coordinators are linked together. So the training program at Sinai and the training program at University of Chicago around this collective group of care coordinators performing different roles in this overall kind of ecosystem of how you create care transition are working closely together and will be aligned closely together as they are assigned to emergency rooms and community health centers. They'll be working closely together to close the gap around access. And while the community health workers will be working to help address social determinants of health and some of the navigation issues, the care coordinators will be working alongside them to help with care transition and supporting those things. And that model in and of itself, just creating a model of care coordinators and community health workers working together, linked that closely together to the primary medical home, to emergency rooms, to community-based organizations, should help really it fundamentally close the gap in what we're seeing around access and navigation.
That's a great addition, Brenda. I mean, again, the more we hear you all discuss this, right, there's nothing simple about this answer. It really has been a multifactorial solution. And, you know, Barrett, as someone who's been on the board and the planning and design from the beginning, what's it been like for this group of, quite frankly, very senior executives, right, to get this off the ground? How have you all made decisions? What's worked well within that governing structure? What's something that's kind of evolved over time?
You know, it's interesting. when you pull together a group of senior leaders to start a process, because we're all used to having huge staff of people around to sort of push things off to. We have ideas and creativity and push ideas out there and watch them be implemented. In this case, we were building this model together. So as you can imagine, there were a lot of different ideas about how we ought to get this done, what it should look like. And so to your question earlier to Erica about trust, we had to trust each other. Because again, we are 13 organizations in the same community, serving the same community, and in some cases competing for that service in the community. Now we're coming together to work together. You really think so? You know, you got to keep your eye halfway open, you know. So we had to work through those challenges. And I am so happy, so proud of the way we sort of worked through those challenges, because the one thing that kept us focused was that we were there for the same purpose, and that is to provide better access to healthcare, good quality healthcare to everybody on the south side of Chicago. And so we're not a perfect group, but I can tell you we strive for perfection every day. So it's been challenging in two fronts. One, learning to work together as 13 separate organizations, and then as 13 leaders of those organizations, having to pull up our sleeves and truly understand the real meaning of work again by getting it done. And so we have this board of directors that meet every week. Who does that, right? Meet every week. And the executive committee meets every other week. And then there's all kind of other meetings going on. But we have also dedicated this process that there's not a time where we're not all represented or all fully engaged. It's been more than a challenge, but it's been a challenge that we have all accepted. It's not something that's been forced on any of us. We are all fully engaged in this process because we're all serving the same community and been serving the same community for a long time. We've just been doing it in our own individual ways. So to your question, Nate, it has had all of the challenges one could imagine when you bring together 13 different organizations and 13 leaders of those organizations, because we have not chosen to put other people at the table. We've taken the presidents, the CEOs, the leaders of these organizations, and sat them at this table, asked them for their time and their commitment, their ideas, their thoughts, and their willingness to work through challenges. Now, we've had some really good meetings. We've had some really tough meetings on the front end, and occasionally we get a tough one every now and then. But we all sit at that table and we work through it, which is unlike what typically happens in our community. We fight and go our separate ways, take our ball and go home. That's not the case here. And I love this dedication of this group. And it's something that the community can be extremely proud of. And the other thing is, you can ask any one of us, any 13 leaders on this board, any question you want to about what it is we're doing in this model, and we all can give you a response because we're all fully engaged. It's not 2 or 3 people who are doing it. It's not 2 or 3 systems that's leading it. We are all fully engaged, and that's absolutely rewarding. And I say all the time, we will be able to stand tall 5 years, 10 years, 20 years from now, and be really proud of the work that we've done that's been sponsored by the community that we serve.
Can I just add to that, Barrett? That was very well stated. What I have found interesting, representing one of the organizations in the coalition, but more importantly, representing all of us to build this connected care platform. When I come back into my organization and I share what's going on and what the thinking is around the technology platform, there is definitely some raised eyebrows. How are we going to do that? And what's our role going to be? And I think there is some disruption that's going on within each of the individual organizations about how do we actually transform the care using the technology. And it's definitely made us get more reflective on how do we work with our partners and how do we bring our organization internally along with the vision that we're all creating and you guys are leading for the South Side. So I guess my point is, we're senior leaders coming together to solve this, to address this problem, but then we go back home to our organizations and we have to advocate a different way of thinking in order to carry out the vision and the objectives of what's taking place within that within the leadership of the board and the various care committees. And I found that internal disruption super healthy for us at Advocate Aurora Health, because it is like boots on the ground, changing the way we deliver care, is making us think differently about how we do boots on the ground and deliver care, not only in the south side of Chicago, but throughout our footprint and our growing footprint as we come together with Atrium. One of our key differentiators is health inequity, and how do we address it? What we're learning here is so applicable to what we're going to need to do broader. And I just want to also say one thing. We're not like the first people to do this. There's a really great HIMSS resource that's out there that is from the Parkland Center for Clinical Innovation. They put together a roadmap on building connected communities of care. And it's a really valuable publication from HIMSS, and I would highly recommend anybody on this call or anybody who's interested. We've used that roadmap. We've changed it. We've gone in a little bit different direction, but I think it's really important to point out that we're not the first to be doing this, and there's some other really great ideas out there. But I think what we're doing is super transformational and different, and the outcomes will speak for themselves. I think there's just we at the connected and the technology side, we're looking globally at what others are doing and not just trying to think locally, because there's other groups that are doing things that are similar-ish, and we're trying to bring those to the south side to make this the best platform we can deliver.
Well said, Russ. I think that's just that's an important reminder, right? That you don't have to start from scratch every time through. Sure. Brenda, I wanted to direct a question your way. We heard a great story from Barrett about how the senior executives came together and they're meeting weekly on board meetings, executive committee meetings. There's a whole other group of people also who are helping to bring this to life. Can you share with the group a little bit about kind of this implementation structure that the group stood up and how that's worked?
Yeah, and am I the only one hearing a vibration?
Yeah, there's an echo.
Okay, all right. Okay, so yeah, so thanks for that question and to just the answers that all of my colleagues just gave about, just insight into how this is actually coming about. But one of the things that, has been incredibly helpful to this process is that we are all leveraging our teams to help us execute this as well. I wanted to do this early on, but I do want to thank Chartis for just the work that they did with us beginning back 2 years almost in helping us not only to put together our model, helping us to think through some of these things that I think helped us land where we've landed today, but also helping us to establish our implementation management process. So we have stood up and we stood up very early on an implementation management office that worked alongside with Chartis so that we would have a transition plan when Chartis was no longer helping us in that work. And so our implementation model is led by an individual with long-standing project management experience, but alongside several other project management leads that are leading work groups. And Russ is one of those folks leading a work group in technology. We have, I think, about 8 different work groups that are working on every aspect of this model. So we have a work group that's helping to drive the care delivery model that we've designed. We have work groups working on our social determinants of health and the community-based organization, the connection with the community-based organizations. We have one working on building our HR and finance efforts, and we've contracted with a fiscal agent that's serving as the CFO, so to speak, for the SSHCO until the SSHCO actually gets its own. We hire our own. But there are multiple work groups that are working together to build the model, and then they come together to ensure that as the model has been built and we're executing it or operationalizing it, that these teams are working together to ensure that the work is connected and that none of this is being developed in a silo. So we're in the operational phase of execution phase of our model. And so the building phase was the early phase. We're in the execution phase of the model. And so these teams are working very closely. And to Russ's point earlier, the care model design team is working very closely with the IT design team to ensure that the the technology system supports the care delivery model. And so all of that's working together under the structure of an implementation model. And that group, Barrett said that the board meets every week, but that group meets multiple times a week. So there is a lot of incredible dedication. And in those work groups, we have our teams from across all of our respective organizations helping to actually deliver that. And so yes, we as the board are working and actually doing the work, but we've got our teams busy at work as well, working on these things also.
Great, thank you, Brenda. Another question came in sort of just to open up to the panel, which is how do you eventually see this organization working together with community-based organizations to address social determinants of health? So anyone who wants to take that one, unless you just want me to pick.
I'll start it and then hand it. Erica, were you going to take it? You came off.
Yeah, I was happy to start it.
Please.
So I think that, and I think that Brenda's earlier remarks in terms of really speaking to the model in and of itself really showcases this. But not only are we a collaboration of 13 participating organizations made up of the makeup that was already described, the FQHCs, the safety nets, as well as the academic health systems, but also part and parcel of our healthy community organization is a coalition of various community-based organization partners, if you will. So we have really identified the top challenges and top social determinants of health and really cast a wide net to really understand. And part and parcel of this is to do a request for information among the various community-based organizations out there that really address those particular needs that we're looking to solve for. Because we want to leverage them as anchor partners in this particular process. So this is still an evolution, obviously. So I don't think we fully arrived at our full core set of community-based organization partners as of yet. But I think that that's a work in progress towards doing that. Some examples of community-based organization partners is multi-purpose community-based organizations that really address the various social determinants of health. Are very focused community-based organizations that really address particular drivers. And I'll just use an example. Housing insecurity is one particular challenge that is out there. And we know that we can't solve for the bigger solution without really resolving some of these social challenges that we're faced with. So we're looking for specific community-based organizations that have an expertise in really driving strategic solutions to addressing that challenge. Other core examples of community-based organizations are organizations that actually have a solution for the transportation gaps that are out there. The food insecurity issues that we're working with. There's various collaborative partners there. But just to go a part of some of our anchor goals, our goal in part is to work directly with community organizations that are a part of the neighborhoods that we're really servicing. So it's a mixed methods approach, if you will, to really addressing that. And Brenda, I don't know if you want to add to that.
I think you summed that up quite nicely. Thank you.
Can I just add, a component to this? So the way we're looking at the technology side of this work is we're looking at a primary connected care platform, and then we're looking at some specialty add-on components, and the specialty add-on components is looking at niche vendors around CBO referrals. So there's some powerful entities out there that do a lot of powerful, important work in terms of identifying various community-based organizations and allowing us to do referrals within our connected care platform to those CBOs using a niche vendor solution on top of our connected care platform solution. So we're looking at two major components of this connected care platform, and one of which is critical to the CBO connection.
Thanks for the ad, Russ. I just saw a question come in the chat from Leslie Evans, and the question is, I'll open to the panel. Does Chicago have a program in place to use Medicaid dollars to fund housing for homeless populations? Looks like there's an example referenced in Philadelphia. If we don't know, we can follow up, but I thought I would.
Yeah, I don't know if Medicaid does, but I know the city of Chicago does have funding allocated for housing programs, and they're focused largely on housing programs that have the supportive housing programs with wraparound services and case management associated with those. I'm not sure if, I don't know, Barrett or Eric, if you know if Medicaid does.
I would say the same thing the city has.
Yeah, the city does, yeah.
Yeah, I would agree with that. So I know that there's specific funding, and then there's all kinds of creative efforts in the works to kind of use tax dollars a little bit differently and creatively to address some of the housing needs. Medicaid is more at a state and federal level, and I think that in part of the work of our collective collaboratives is actually coming together to really drive that synergistic strength to really drive transformation in Medicaid funding in and of itself, to actually fund the various social determinant programs like transportation, like housing, like other things. So I think that that's a work in progress at the state and federal level.
Thank you. And Leslie, thanks for sharing the additional content in the chat. Looks like there's a New York Times article if folks want to go a little deeper there. Russ, a question for you. We've been circling around this in different ways around the technology design, but that has to sit on top of use cases and workflows pretty specifically. Could you share an example of a specific workflow or use case that sort of came out of the clinical design work and is now being fed into some of the IT design?
Sure. Let me give that a thought for a couple seconds here. All right, let's do, so say a patient arrives in the ED, and we need to get that new patient enrolled and do some initial screening and get them connected up with a care coordinator. So there's a specific set of workflows that will be enabled in the technology solution that will allow us to do some triaging, some risk assessment, some stratification of that data, and then the proper referral to the right care coordinator or to a provider, primary care provider, or a community health worker. So there's that one in the ED. Then there's another one having to do with RN care coordinator services and how we get those patients connected up with those RN care coordinators. So there are workflows that we're looking at in terms of building into the connected care platform that will allow us to review the chart in an EMR from any of the historical institutions, and then be able to coordinate that care across the various provider or care team delivery folks. So those are two that I have in my mind. We also have some mental health and substance abuse screening criteria that we're looking at in terms of folks that may show up in an emergency room or at one of our partner organizations. The Connected Care platform is largely focused on patient identification, doing assessments, risk stratification, and then closed loop referrals, and then appointments to specialists or primary care providers.
Great, thank you. Thank you. And you mentioned behavioral health. Barrett, if I can put you on the spot just for a minute, FQHCs and organizations like yours have really been focused on behavioral health for a long time. What do you think could be different coming out of the healthy community model that either wasn't there before or is going to be better or just different? It's long been an area of focus.
Yeah, I think that the one thing that's going to be better is the fact that we're going to have more behavioral health providers, which will give greater access. We're looking to bring in some 50 providers in that area. And as you said, many FQs already offer behavioral health care. But what we have found in this pandemic is that the behavioral health issues and concerns have become the second pandemic. And so we can't have enough of behavioral health care in the community, and particularly on the south side of Chicago. We here at Chicago Family Health have this warm handoff model by which every patient who comes to see us fills out what we call a PHQ-9, sort of a stress test, if you will. And if they score in certain areas of this test, or their provider, healthcare provider, seem to think there's some reason this patient would benefit from a behavioral health conversation, we hand them off right at that moment. Well, that has become such a huge process today that we find ourselves challenged to meet those needs. And so that's just a small example of the challenges from a provider standpoint that we have in behavioral health. And so we use everyone we can in the community to partner, but we're all stretched to our limits in behavioral health. So one of the things this model will do will be to increase the number of behavioral health providers across the south side of Chicago. And we're going to do that in any number of ways and different levels of health providers. So that greater access will help.
Yeah.
Well, can I just add? Yeah, can I just add a small piece to that? Just because it's not just behavioral health. I think the marriage of behavioral health and addiction services and substance abuse disorders also comes into the forefront. And some specific trends that we've seen is we've seen an oversaturation of individuals with either mental health or substance abuse disorders, or a combination of both, and a combination of even these chronic conditions and diseases actually show up in an emergency department. So we're actually seeing a trend from prior to the pandemic of being on average 30% of patients present now is actually rising to a point where we're actually seeing upwards of 60% of patients who come in either qualify in that way. So one of the very innovative aspects of this model is to really look at it as a full ecosystem and full continuum. So we're not just treating the mental health side of it. We're looking at the collective and the addiction services and substance use disorders is a major aspect of that as well. And that certainly is not getting missed in the model.
And if I might add just one other piece, and that's around the culture of receiving behavioral health care. We have been challenging our community in that aspect. And so I think, again, to Erica's point, it's not just behavioral health, it's substance abuse, it's the alcohol problems, it's on and on. But one of the things that we're trying to do as we provide a wider access to care is to reduce the stigma of receiving that care and how and where you receive that care. I say this all the time. I know people all over the country, And I don't know anyone who at some point in their life didn't need to talk to somebody to work through a problem. Now, whether they
That's
decide
right.
to do it or not was the
Mhm.
answer.
Yeah.
But for us, we're trying to make sure that there's access to that
Mhm.
level of care.
Yeah, and I would just add to that, in the Department of Health and Family Services, the Medicaid department, outside of our transformation model, they're also supporting and funding additional resources for behavioral health. I think one of the challenges we're going to have is just getting the workforce that we need to actually execute on our plan, and then the broader work that's happening through HFS to support the behavioral health needs that our community has, and of course communities across Illinois have as well. But one of the things that we have seen as a result of the pandemic, a trend that we've seen, to Barrett's point about the stigma, is that more individuals have recognized the need for behavioral health because of COVID than I think we've ever seen in the past. And I think people are saying that, stressing that in ways of talking about stress and depression and loneliness in those ways. And so it's enabling us to recognize the need for behavioral health services in a very different way.
All of which needs to be supported with really great data analytics.
Yeah.
So that we can really do a good job of understanding what's in our cohort, where the gaps are, and where we can strategically focus the resources of the SSHCO. So a key component of how we're looking at the connected care platform is the power of not only traditional data analytics, but also the power of predictive analytics. And so we're thinking about this short-term and long-term in terms of the connected care platform. And I think one of the most exciting parts of it is how are we going to leverage the data to really be as strategic with the limited resources and providers and other healthcare workers that we need to meet the needs.
Yeah.
How did you all go about getting started? Like, how'd you pick what to do first? We've heard a lot about mental health. Brenda, you shared a number of other just incredibly pressing challenges around life expectancy, prenatal care, infant care. There's lots of places to start. So how did you all think about either patient populations or segments or conditions? You can't do it all at the same time. So how did you all process that?
I would say, I think we started with the community. We started with, what did the community say were the most pressing needs in our engagement conversations with the community. And clearly the data supports what the community said were the most pressing needs as well. So I think that's where we started. We also started because at behavioral health, we know it's a need, but it's also one of those common metrics that HFS wants to measure across all the transformation models. And it's also, as you just heard, a need that's been around for a long time, but a growing need in our community. So this is a common approach. And so a combination of the community's perspective on needs, the data, and HFS, but behavioral health, maternal child health, hypertension as a chronic disease, those are the things we're starting on.
Great. Brenda, you also, we appreciate the history you gave of the South Side and how it's really changed over a generation or two. It may be worth just sharing a little bit, whether you want to do it or another one of the panelists, how this collaboration is actually going to try to be more of an engine of jobs and economic vitality for the South Side. That was kind of an important part of the commitments back to the state, I think.
Yeah. Barry, did you want to start?
Yeah,
I
just a little piece on the front end. I would say to you, Nathan, that is going to be one of our greatest challenges to success, and that is the workforce. We are focused on providing job and opportunities for those who live, not for those who live on the South Side of Chicago, that will also be serving. But we do recognize the challenge just nationally around workforce issues. And so here again, we have our own individual organizations that have this workforce challenge, and collectively, this model has its workforce challenges. So I would say to you, that's going to be the number one challenge that we're going to have to figure out how we work through. In many cases, we are going to develop, groom, and develop people to join the workforce. But in some cases, we're gonna have to find another way because the people to be groomed and developed are not there. How do we start from scratch? Quite honestly. So this is going to be for the people, by the people, with the people. That's the way we're going to get it done, but it's going to be a challenge.
Yeah, and I would say that, you know, all 13 of our respective organizations, we're on the South Side. So part of our own missions are hiring from the South Side. I know at UChicago Medicine, our goal is to hire at no less than 40% of our workforce from the South Side. About 25% right now are hired from the South Side. The point is, where is the workforce that's going to, well, first of all, the workforce is there. We know the unemployment rate on the South Side is around 16%, and the most unemployed are persons between the ages of 18 and 24, largely male. And so there is a workforce, 85% have a high school degree at least. And so there is a workforce there. We're going to have to nurture the workforce, build the workforce, create maybe some cognitive behavioral therapy resources that will help persons on the South Side establish within this sort of structured workforce. So there's a number of things that we're going to have to do. I think this is a place we're going to have to seriously work with community-based organizations. We're going to have to seriously work with some of the minority-owned and women-owned businesses that are not minority-certified businesses, and elevate them to this certified status. There are a number of things that we're going to have to do that we will be able to do as a unified system of employers on the South Side that we couldn't do independently. So I think the SSHCO has really set us up in a position to enable us to be much more powerful at building up a workforce, developing a workforce. To Barrett's point, is that not just finding the existing, but developing and building up this workforce. We'd have to do that in a concerted way.
I would just add to that another aspect of this is creating avenues of a different job class, if you will. So in part, partnering with the community colleges even to build up nursing programs designed and tailored to care coordination, building up programs specific to certify community health workers and provide just a different avenue. And then that partnership with the various city colleges of Chicago, for example, is just opening up the doors through those various channels. So I think that is another aspect of that economic engine that we're actually building up. One of the things I'm particularly proud of this organization that we've stood up is we've essentially led by example by leveraging only minority-owned, women-owned vendors, even as we're partnering in different aspects of really standing up and implementing our model. So even the behind-the-scenes aspects of what we're doing that's really serving as the driving force behind this. We're leading by example and starting out the gate strong and being able to represent that in a positive way.
Yeah, absolutely. Folks, I'm seeing we've got a few minutes left, and rather than kind of closing comments or a benediction here, how about the same question for each of the four panelists, which is, you know, you've shared a lot of great experience today on kind of how this has come together, some of the challenges, some of what you're excited about. What's the one most important thing that you would tell someone else who wants to get this started in their local community?
I'll go first before all the good answers are snapped up by my friends. For me, I think one of the things that I would say is that you gotta start with the community. Again, as I said earlier, we too many times we try to fix what we consider to be problems by doing what we think is best for those we're trying to support. rather than asking for their opinion. And so, but that comes with a lot of promises. If you ask for it, you better be willing to deliver and be held accountable for it. So I would say start with the community, continue with the community, have the community involved at every level that you can. And that, I think, puts you up in a position for greater success for providing the level of care that you want to. So start with the community, keep the community involved throughout the process.
Of course, that's the best answer, Barrett. But,
Then what's the
but,
second thing you would tell people?
well, obviously you can't do this without resources. And there is a case for the need for transformation, not just in Chicago, on Chicago's South Side, all over the country in communities that have been disenfranchised and marginalized over years and has lost healthcare, lost resources. And so the case for it is really important to be, to build, to actually seek funding for it. And there's obviously, I don't know what's happening at the state levels, but there's philanthropy and there's other resources that can be accessed for some of these funding. You might have to start small if you're doing it. And that's okay if you begin small. Most people don't get $146 million over 5 years to do something like this, but there are capabilities within communities to do this. And the last thing I'll say is this: you have to do it. You can't go alone at something like this. The success of Parkland, success of a lot of the district programs from around the country, this transformation model is that it was a collaboration. It was a coalition, and you've got to do it that way in coalition with other not just healthcare providers, but the ecosystem of providers, the CBOs, public health, and a number of other entities to get this done.
Right.
So I would say that Barrett and Brenda took the best, the top two answers to that question. But let me just add on that this is not a one-size-fits-all approach for sure. You can't go at it as a cookie cutter model. And as Barrett alluded to, this truly needs to be iterative, and it needs to grow and develop over time with and for the community at large. You also, being a collaborative and being coming together and really forming this, you have different egos, different agendas, and you really have to really check your title and check your ego at the door when you're coming into a collaboration like this, because at the end of the day, that the true North Star is truly the community and the needs of the community. So you have to really block and tackle to really drive at that and really demonstrate early credibility to continue to build on really unpacking that trust that has been let down for so many years. And then last thing I would say is you can't really approach this by boiling the ocean. You have to have focus and deliberate, intentional focus on what it is that you're trying to do. And as a collective, collaborative, really couple all of the various resources and your strengths from the collective organizations together to really drive at that.
Great, thank you. Russ, you're on mute.
Sorry about that. And I know there's a lot of technology folks on this call. Just from a technology perspective, our guiding light has been clinically operations driven and IT supported. And I think listening to the frontline healthcare workers who are going to be using these systems and what we're hearing from the care teams and the care team leaders, really listen to the need of the frontline worker who are going to be using the technology systems, and make it simplicity of use. And the other thing I would say is I might do it a little bit differently next time and bring in some of the vendors earlier and have them do a demo before we necessarily define all the requirements, and run a parallel track, do a traditional requirements gathering but maybe bring in the vendors a little earlier to hear what their capabilities are and see where that synergy is earlier on in the process. We're going to be in good shape with the model that we've used, but I think maybe think differently about how to engage vendors earlier on might be something that we would do differently if able to do it again.
Well, that was a fantastic way to wrap the panel. I would never presume to speak for the panel, but I will say thanks to HIMSS and the group for having this group here. It's been just a joy to listen to it and to kind of live it all over again. But thanks so much for Barrett and Erica and Russ and Brenda for being so open and honest and generous with your time today. Lisa, I'll pass it back to you to take us home.
Yeah, well, thank you, Nathan. Thanks to you as well. And thanks, really on behalf of HIMSS and all of us in the audience today. Thank you all so much. This was just a fantastic panel, giving us some great information. And I also really just want to thank you as leaders. You have shown tremendous leadership in really helping to drive transformation in your community. So thank you. Thank you for that as well.